We have 15 minutes more, I think. 11 o'clock.
Yes, sir. Yes, sir. Yeah, we are live on YouTube.
Okay. When is your presentation?
Next Monday.
Monday, okay.
4. In another 5 minutes, I'll start permitting others, sir. 5-10 minutes.
Yeah.
But this program is hit us, sir. Yeah. Almost like around 500 people are attending on Zoom, and around 200 people are attending on YouTube.
Okay,
and people from outside India are also there.
Okay, right. Okay. So
from Nepal and other countries.
Okay. Probably this we can continue even after this lockdown, monthly one.
Yes, sir. Yes, at least monthly one.
So many webinars nowadays. Audio is clear?
Audio is clear, sir. Fine. Now I will mute myself and I'll switch off my video.
Yeah.
And I'll permit others now.
Okay.
We're ready to go. 11 o'clock will start, sir. Sharp 11 o'clock.
Okay, you just tell me, I'll start.
Yes, sir. Yes, sir. A very good morning to all dear friends present here. As we start one more week in lockdown, we are here with a very new lecture series, the fourth part of this lecture series. The speaker for today is Dr. Anil Melat sir. Sir is a past president of Indian Society of Pedontology and currently working as a principal professor and head department of periodontics and implantology at Mahe Institute of Dental Sciences and Hospital. Over to you, sir, to start the session for today.
Thank you, Dr. Neeraj. Am I audible?
Yes, sir.
Yeah, good morning to everyone. Let me first take this opportunity to congratulate Dr. Nimfia Pandit, President of Indian Society of Odontology, and Honorable Secretary Dr. H.S. Grover, sir, for taking the initiative of starting this webinar series, especially during this lockdown, for the benefit of exam-going postgraduate students. As well, acknowledge and congratulate Dr. Neeraj, who is the Treasurer of Indian Society of Odontology, for coordinating this webinar series in an exemplary manner. Hope you're all staying safe at home and we're all going through a tough time. I'm sure that we all can face a better tomorrow. So the topic given to me is to discuss on implant complications, peri-implantitis, and its management. Now we all know that we are all fighting this dreadful disease, COVID-19, and our deepest sympathy and prayers and condolences for the COVID victims as well. At the same time, let us all congratulate as well as acknowledge the effort taken by the health professionals, health authorities, government, as well as police authorities for working day in and out and making sure that we're all safe for a better tomorrow. So with this, I start my presentation on implants, complications, failures, peri-implantitis, and its management. Hope I'm audible, Neeraj. Can I go ahead?
Yes, sir, you're audible. Please go ahead.
Okay. Now, we all know that dental implants is the key option in replacing any edentulous area. Where we talk about the fixed option, the first option what we give the patients are dental implants. Now, the availability of the dental implants definitely has created a revolution in dentistry. And now we can see that various dental implant systems are available with different designs, different thread designs, different length, different surface topography, all to enhance osseointegration. Along with that, the availability of zygoma implants as well as cortical implants. Now, so dental implant practice is a practice what every dentist nowadays they incorporate in our practice. So it is important, equally important to know that when you place it into dental implant, what are the complications, what are the failures, also what you encounter in a dental implant practice. I always believe that placing a dental implant is easy, but maintaining a dental implant as well as understanding the failures and complications of dental implants is equally important, which will lead to the success of your dental implant practice. That is why I have heard a couple of senior dental implantologists saying that if I can manage a failure, I am a successful dental implantologist. So it is very important to us that you know the failures to understand how you go about the treatment of dental implant failures. Coming to what is a dental implant, according to Glossary of Periodontics 2001, it's an alloplastic material or device that is surgically placed into the oral tissue beneath the mucosal or periosteal layer or within the bone for functional, therapeutic, or aesthetic purpose. So basically, you are replacing a natural tooth and getting the function, aesthetic, and therapeutic part by placing a dental implant. So that is what we have to achieve as a surgeon, or from the patient point of view. Also, they should be happy functionally, as well as the aesthetic concern is also one key factor in placing an implant which is successful for the dental surgeon as well as in the patient point of view. And what we are achieving by placing a dental implant, we all know that we are eager in going to achieve osseointegration. Now, the father of implant dentistry, Branema, he has defined osseointegration as a direct connection between living bone and a load carrying endoosseous implant at light microscopic level. Now, when you see a direct connection, any interference with this direct connection between the bone and the implant, there is a chance of failure of the dental implant. So we are placing a dental implant. We are making modifications in the dental implants to achieve or enhance osseointegration. So any there is any problem, any also wherever there is a wherever there is a deficiency in the osseointegration, or where there is a deficiency in the connection between the living bone and load carrying implant for various reasons. It can be an infectious failure. It can be because of the trauma to the prosthesis. So all these factors causes definitely a failure, which can lead to failure in the osseointegration, leading to the failure of an implant, which will be talking to you later when you talk about the implant failures. Now, when you compare the tissue, what is the basic difference between the periodontal tissue and the peri-implant tissues? When you talk about the natural tooth, you have periodontal ligament and cementum, while in case in case of an implant, you have a direct contact between the bone and the implant. That is why we say that the connection of in natural tooth is a resilient connection, and in case of a peri-implant tissues, it's a rigid connection. So when you compare these both, that is why we say that many articles in the literature quote that you cannot connect an implant to a tooth when you give a prosthesis, when you give a fixed prosthesis, because there are articles saying that because you don't have this adaptive capacity of cushioning effect what you have in the natural tooth in an implant. But there are majority of the articles are stating that it's always better that for the prognosis of an implant, it is always better to connect an implant to an implant. So this is the basic difference when you see the tissue quality between the periodontal tissues and the peri-implant tissues, and the remaining all the differences as mentioned here we have highlighted. So these are the basic difference. So that is the reason why always we say that it's always better for the prognosis and to avoid failures, connect implant processes, do an FPD only, connect an implant to implant, and try to avoid connecting implant to a tooth. But there are articles showing that showing and justifying that the connectivity between the implant and the tooth is also possible and showing prognosis. Now, what we are achieving as an implant success. Now, when I place an implant, I am looking forward to place an implant without any complication. And I want to achieve an implant that remains stable and functioning without any problem. As well, the peri-implant hard and soft tissues are healthy. And finally, very important, patient and the treating clinician are pleased with the results. This is the success mantra, what I would achieve as an implant practitioner. And this is what we are looking forward for a successful implant practice. Now, coming to complications, what we can encounter in dental implants. Now, like any other surgical procedures, now the first thing what we can face is accidents during the surgical procedures. And second thing is complications during the procedures. During the procedures, you can encounter accidents. For example, in implantology, if the drill can puncture the nerve, artery, all this possibility because of your lack of skill, all this can happen because of because in your implant practice as well. Many times what we see that the accidents and complications are very, very important to identify and treat at the earliest. So complications, in this case, we divide complications into early and late complications. Now, under early complications, we are expecting infection, edema, ecchymosis, hematoma, emphysema, bleeding, all these factors which normally we have in majority of the surgical therapy. And later stage complications in implants, we can have a mandibular fractures, maxillary sinusitis because of your drill or the implant placed in the sinus region, failed osseointegration, bony defects, and peri-implantitis and periapical implant lesion, also perforation of the mucoperiosteum. So this classification was given by Misch and Wang and in the Journal of Implant Dentistry in 2008. And they are broadly classified into two categories, that is early stage complications and late stage complications. Now coming to the complications, classification of complications by Carenza, they have classified into four headings. One is surgical complications, one is technical complications, one is biologic complications, and the fourth one is aesthetic and phonetic complications. Now, surgical complications, as we discussed earlier, complications related to surgery, and technical complications are any prosthetic complications such as screw loosening and fracture or implant fracture or fracture of a respiratory material can be put under the technical complications. And biologic complications are due to the pathogenic microorganism setting in, causing peri-implantitis or later dehiscence, recession, inflammation, and later causing the implant loss or failure can be put under the biologic complications. And finally is the aesthetic and phonetic complications on the patient side, not satisfactory after the placement of the implant. So these are the two classifications of implant complications. The first one is early stage complication and the late stage complication by Misch and Wang, and followed by the second classification by Carenza, that is classification of implant complications, which have been described in four headings as surgical complications, biologic complications, technical complications, aesthetics, and phonetic complications, which is generally self-explanatory. Now whatever we say when the implant fails, the surgeon can say that it was successfully integrated but failed because of excess loads. But the restorative dentist also can say that implants were poorly integrated and so failed under normal masticatory loads. But finally, the patient's tale is the implants have failed. So it is important to understand what are the complications and what are the failures you can encounter, because finally convincing a patient after the implant failure is not as easy as placing an implant for the first time. So it's always better that you understand the complications, you understand the implant failures, and take necessary action prior so that it will help you for long-term prognosis of your dental implant treatment. Now coming to the positive factors what we consider for the implant success. First, definitely I would like to have a bone type that is density D1 or D2, more of cortical bone, less of cancellous, because for a better osseointegration, and patient healthy, preferably less than 60 years old. Mandibular placement, because mandibular placement, one is the ease of placement. Second, as per literature, the mandibular prognosis in implant placement is much more than the maxillary. Implant length, and I have 2 implants or 3 implants placed and going for FPD processes for a better anchorage. Axial loading of an implant, regular post-operative recalls, and good oral hygiene maintained. These are positive factors what we look into when you do an implant practice. Now, other than this, negative factors, we all know that when it's a D3 or D4, the prognosis is poor, low bone volume, any systemic factors, smoking, maxillary, particularly the posterior region, short implants, and inappropriate early clinical loading, and definitely bruxism and other parafunctional habits. These are negative factors, and that are positive factors which definitely help in prognosis. And the warning signs, more importantly, what we have to look into is, one is pain, second is gingival bleeding. So the patient normally, when in case of peri-implantitis, the patient comes with a dull radiating type of pain. And in case of gingival bleeding and enlargement, and second is purulent exudates from the pockets. Angular bone loss can be seen in peri-implantitis, and also fracture of prosthetic components, long-standing infection in soft tissue, connecting screw loosening and connecting screw fracture. So when a patient comes to you with these warning signs, many times it's important, and we all know that we take the necessary X-ray or CBC to analyze whether it's just a screw loosening or whether the patient is having peri-implantitis, because that's once you diagnose that, it's easy for us to understand the prognosis part and how to go about the treatment. So these are the warning signs of some of the implant failure and the other positive and negative factors. So we have already gone through the complications classification, then positive factors, negative factors, followed by warning signs of implant failure. Now going to the classification of few implant failures. Rosenberg et al. Classified as the implant failures into 2 categories. One is an infectious failure, second is a traumatic failure. Infectious failure caused by microorganisms, similar to a periodontal lesion, And traumatic failure is basically the lack of clinical sign of infection and demonstrate few or no more periodontic pathogens. And it is basically they are contributing only to anything related to traumatic occlusion, which is causing, or any fracture component of the prosthetic part is causing the failure, is under traumatic failure, and other one is the infectious failure. So broadly, they are different. Broadly, they have defined this classification into two: infectious failure and traumatic failure. And the second classification by Esposito et al., they have classified broadly into four headings. One is biologic failures, mechanical failures, iatrogenic failures, and inadequate patient adaptation. So when you talk about biologic failures, they have considered the loadings. If the failure is before loading, before the second stage, it's early or primary, and after loading, it is late or secondary. And mechanical failures are basically due to fracture of implants, connecting screws or bridge framework, etc. Anything related to the prosthetic is mechanical failure. And iatrogenic failure is basically to the surgeon, where improper implant angulation, alignment, or nerve damage is calling iatrogenic failures. And finally, it's an inadequate patient adaptation, which is phonetics, aesthetics, or psychological problems. So can be put under the failure of inadequate patient adaptation. So this classification gives you a picture of biologic component, iatrogenic component, mechanical component, and inadequate patient adaptation component. Well, in the earlier one, we had only two failures, that is infectious failure and the traumatic failure. And the third classification, what we go into, is the classification of Escari et al. On implant failures. And in this, they are classified under seven subheadings. First is according to the condition of failure, that is before stage 2, and second after stage 2 and after restoration. And second is according to etiology, whether the failure is due to restorative factor, host factor, surgical factor, or implant selection factor. And according to the timing of failure, whether it's ailing, failing, failed, or surviving implant. Now, ailing, failing, or failed, I'll be talking in detail when I talk about the peri-implantitis. According to failure mode, it is psychological problems from the patient side, lack of osseointegration, unacceptable aesthetics, and functional problems. And according to origin of infection, it's whether due to peri-implantitis or it's whether due to retrograde peri-implantitis. And according to supporting tissue, soft tissue loss or bone loss combination. And according to responsible person, it can be dentist, dental hygienist, or because of the laboratory technician or patient. So they have broadly divided into seven subheadings. That is conditions of failure, etiology, according to timing of failure, according to failure mode, according to origin of infection, according to supporting tissue type, and according to responsible person. So these are the three types of implant failure classification which I have highlighted today. So we have finished off with the implant classification of implant complications, followed by classification of implant failures. And from here, we move on to our topic as peri-implantitis and its management. Now, here, when you go to the peri-implantitis, we have ailing implant, which we discussed in the classification earlier, ailing implant, failing implant, and failed implant. Now, what is an ailing implant? We always say that failing is not always a failure, because here we understand that what is the involvement of the supporting tissues or the peri-implant tissues to understand the treatment aspect. So this is very important to understand what is ailing, failing, and failed implant. When the problems is limited only to the soft tissues surrounding the implants and not involving the supporting bone. So I repeat, it is limited only to the soft tissue, not involving the supporting bone. It is called as an ailing implant. And failing implant is that shows progressive loss of supporting bone. There is a peri-implant pocket that is clinically, but the implant is clinically immobile. And failed implant is one that is clinically immobile. So this gives you a picture when you get a case, how to go to the treatment line or how to diagnose it, whether it is ailing, failing, and failed. And normally, because it's very important, the prognosis for the ailing and failing is good, while in case of a failed implant, normally we go ahead with the retreatment by removing the implant and going for a replacement of the implant possible. So this is the three types of implant failures. One is ailing, failing, and failed. Now, recently, this is termed as a biological complications, and many times on the exam point of view, when they ask the biological complications of implants, you will have to highlight on ailing, failing, and failed implants as such. Now, according to the first European workshop of periodontology, now peri-implant disease is defined as a destructive inflammatory process affecting the soft and hard tissue around the osseointegrated implants, leading to the formation of peri-implant pocket and loss of supporting bone. So this definition, we discussed earlier that about the ailing failing involving the soft tissue and hard tissues around the osseointegrated implants. So this is a definition given by the first European workshop of periodontology. Now, peri-implant diseases are broadly divided into two categories, that is peri-implant mucositis and second is peri-implantitis. So if the inflammatory changes, which are confined only to the soft tissue surrounding an implant, we call it as a peri-implant mucositis. And in case of peri-implantitis, progressive peri-implant bone loss with a soft tissue inflammatory lesion. So this is self-explanatory, saying that when the inflammation is confined only to the soft tissue without tissue surrounding an implant, we call it as a peri-implant mucositis. While whether the peri-implant bone loss with a soft tissue inflammatory lesion, we put it under the category of peri-implantitis. Now, authors, initially, many of the literature, what you can see that there is a prevalence of peri-implant mucositis and there is a prevalence of peri-implantitis. There are a lot of literature showing that once you load an implant initially, there are chances of, many times there are chances of crestal bone loss up to 1 mm initially in the 1 year. And now here, this article, a lot of articles showing the prevalence of peri-implant mucositis here and the prevalence of peri-implantitis. So it's important that showing this particular data, that we have to make sure that in the first phase or the first phase after the restoration is the process is placed, you have to have a regular recall protocol to understand that to prevent this peri-implant mucositis getting converted into peri-implantitis. So this literature gives you a correct idea because of the prevalence of peri-implant mucositis and prevalence of peri-implantitis. So it's equally important the role of maintenance therapy in this peri-implant diseases, so that the prognosis of the implant will be good for a longer time. Now, this is a diagrammatic representation of this healthy peri-implant mucosa, peri-implant mucositis, and peri-implantitis. You can clearly see that the involvement of the soft tissue in the peri-implant mucositis, there is a peri-implant pocket of bone loss in relation to peri-implantitis. Now, classification of peri-implantitis, it's classified as early, that's a pocket depth, equal to or more greater than 4 mm, and less than 25% of implant length, bone loss less than 25% of implant length, bleeding or suppuration on probing. This is classified as an early peri-implantitis. The second one is moderate, the pocket depth greater than 6 mm, equal to or greater than 6 mm, bleeding and suppuration on probing, bone loss 25 to 50% of the implant length, which is considered as a moderate periodontitis. And third is advanced, where pocket depth is more than 8 mm and bone loss more than 50% of implant length. So this is give you an idea that somewhat similar to what we said. I'll put it in the category as when it is advanced lesion, we can put this as a failed implant, and while the other two classification, early and moderate, where there is a bone loss, we put it under the category of failing implant. So this is classified by Fromm and Rosen in 2012, and according to this, there is a first classification early. There's a slight horizontal bone loss with minimal peri-implant defects. You can see the diagram. And second is moderate horizontal bone loss with isolated vertical defects, which is the second diagram, what you can see. And third is moderate to advanced horizontal, and the fourth one, advanced horizontal bone loss with broad circumferential vertical defects, as well as loss of buccal and lingual bony wall. So this classifications gives you an idea about failing and failed implants, as well as that gives you an idea how to go about identifying what type of failure, whether it's early, moderate, or advanced type of peri-implant diseases. Now, I go to peri-implant soft tissue bar dehiscence bar deficiencies. This is a classification which has come out Journal of Pedontology in 2019. Actually, this is not a part of peri-implant disease as such, but since for the benefit of the postgraduate students, I thought I'll just mention about the PSTD classification. This peri-implant soft tissue deficiencies are broadly classified into four, that is PSTD1, PSTD2, PSTD3, and PSTD4, with three subclassifications: subclass A, subclass B, and subclass C. Now, initially, this is PSTD1. You can see that the arrow I'm pointing out, so you can see when you compare the implant crown here, the soft tissue margin of the implant crown here with the soft tissue margin of the natural tooth, this is the same line, but you can see that the keratinized tissue or the marginal tissue is thin, the thin biotype of gingiva, which is showing which the abutment or the implant is visible. So in this PSTD1, you have the margins in the same line with the natural tooth. There is no gingival recession in the implant crown, but the abutment or the implant crown is visible. In PSTD2, you can see that there is some amount of gingival recession, and when you draw an imaginary line connecting the soft tissue margin of the homologous natural tooth and the implant abutment crown profile, you see that the crown is placed more on the palatal side in case of a PSTD2. And in case of a PSTD3, now we analyze PSTD3 by removing the crown. You can see there more amount of recession here. And when you remove the neck of the crown, you can see the implant head is more towards the palatal side in case of a PSTD3. So PSTD3 and PSTD4 is assessed by removing the head of the crown, and that is how you assess. And in PSTD3, when you remove the crown, you can see that the head of the implant is more towards the palatal side. While in case of PSTD4, you can see more the recession is gingival soft tissue margin is more apical. And when you see, compare the imaginary line connecting the soft tissue margin as well as the implant crown profile, you can see that this is placed more labally. And when you remove the implant crown and see the head of the implant, this is seen more facially placed. So this is the difference between PSTD1, PSTD2, PSTD3, and PSTD4. I repeat that PSTD3 and PSTD4 is assessed by removing the implant crown. And in PSTD3, the head of the implant is more towards the palatal side. And in case of PSTD4, the head of the implant is more towards the buccal side. So according to this, the treatment aspect can be analyzed. And many times in PSTD4 and PSTD3, you will have to have a prosthetic approach to recorrect the implant prosthesis. While in case of PSTD1 and PSTD2, we can have the correction done by soft tissue augmentation. So this basically connects you to the treatment aspect also. So hope it's clear. This four classification, that is peri-implant soft tissue deficiency 1, 2, 3, and 4. Now the subclass classification, what they mentioned is, you can see this is based on the tip of the papilla. Now when you compare the soft tissue margin here with the tip of the papilla, if the tip of both the papilla is equal to or greater than less than 3 mm, it is coronal to the ideal position of the soft tissue margin of the implant supported crown. So this is they compare the tip of the papilla with the soft tissue margin here. The second one, subclass B, is tip of the papilla is less than equal to or less than 1 mm but greater than 3 mm, coronal to the ideal position of the soft tissue of the implant supported crown. We put it on the category of subclass B. And C is, you can see that what height of at least one papilla is greater than 1 mm, coronal to the ideal position of the soft tissue of the implant supported crown. Here, yes. So this is the tip of the papilla. So here, this is classified into subclass A, B, and C are classified into according to comparing the tip of the papilla with the soft tissue margin and ranging the distance from the soft tissue margin to the tip of the papilla. So these are the subclass A, B, C classification. And as per the literature, the C classification is not applicable to the PSTD1 because as there is no recession pertaining to the PSTD1. So this is a classification of peri-implant soft tissue deficiencies of Peri-implant soft tissue dehiscence by deficiencies in the Journal of Periodontology, which has come in the year 2019. Now coming to the microbial flora, so we have finished peri-implant classification of peri-implant diseases, followed by PSTD classification. Earlier we had dealt with classification of implant complications and classification of implant failures. Now coming to the bacteria microbial etiology of peri-implant disease, many times going through the literatures, we have seen that it's almost the pathogenic microorganisms are similar in the periodontal microbial flora as well as the peri-implant microbial flora. But recently, a couple of articles, what they highlighted is the presence of Epstein-Barr virus and cytomegalovirus, herpes simplex 1 has been, and presence of Candida albicans have found in higher proportions in peri-implantitis sample, which has been highlighted by articles in 2019. But majority of the articles, what we go through, or when you compare it, the pathogenic microorganisms are similar to what you see in periodontal microbial flora and peri-implant microbial flora. Now, factors that contribute to peri-implantitis. Now, the factors that contribute to peri-implantitis, or factors what we have to take care of, which are leading to failure, is we have to assess the patients when you do an implant on a patient with thin tissue biotype or inadequate keratinized mucosa, which we have mentioned, you have seen in the PSTD classification. What are the problems what we'll face when you do place an implant, especially in the aesthetic zone with the patients with thin tissue biotype, the prognosis is poor. Then thin buccal plate. Many times we have to, the diagnostic tool, what we do to place an implant is very important. We have to have a CBCT. We have to assess the thickness and width of the bone and the buccal plate. So if you don't assess that properly with a thin buccal plate, there is always a chance of implant failure. Then placement of an implant adjacent to the teeth with existing periodontal infection. This is also one cause where you see that there can be an implant, persisting periodontal lesion, which is causing the implant failure. Also, immediate implant sites in sites with periodontal disease or existing infection, where proper care is not taken to remove the apical lesion or the periodontal lesion before placing an implant, which also causes a failure in the implant. A placement of wrong implant size, especially many times as a postgraduate students, I'll advise you, or even after you finish your post-graduation, many times we don't have enough implant sizes in our hand when we do an implant practice. So it's always important that if you have not taken a proper CBCT or a radiograph to assess the size of the implant to be placed, when we open a flap, we see that the bone is deficient and you don't have the size of implant, then you compromise placing an implant what you have. So that goes into poor positioning or alignment of the implant, what leads to definitely a failure. Prosthetic part will be difficult, and failure also is one thing what you can expect immediately after the placement of implant. So it is always better to have the diagnostic protocol in line with the proper CBCT taken in your implant practice, especially in your early implant practice, to make sure that you don't land up in an implant failure. This is again poor one diagram or the X-ray on the poor surgical implant placement technique. And distal pontic, you can see here the distal pontic with the implant, which normally we have earlier we spoke about connecting an implant with the tooth. Also, there is a lot of literature which is for and against. But here the distal pontic is not advised in any case of implant because there's an extra load, and definitely that can lead to a failure. So these type of cases normally are cases where we are actually leading to failure, which is unnecessary. So it's always better that see the fixed processes like how we follow the Antis law. Identify implant to implant placement, as well as you make sure that there is no distal pontic attached to the particular implant. And you can see here also they connected the tooth to the implant with the distal pontic, which is definitely a case of failure which you can encounter. Now coming to diagnosis, so these are some of the factors other than the regular negative factors what we have discussed earlier. We have discussed positive and negative factors earlier. So other than that, some of the factors which I would like to highlight contributing peri-implant lesion. Now diagnosis, indices, you can go for an index similar to your periodontal index, plaque index, as you have seen in the class. I'll be talking about CIST classification where they've taken the plaque index. And peri-implant probing is very important. So you have to assess the peri-implant probing depth and you can use a blunt straight probe, periodontal probe. Plastic periodontal probe is automated probe or true pressure sensitive probe, which can be used in case of a diagnosis of a periodontal limb, and also assess the mobility, which will help you in assessing whether it's a failed or a failing implant, and pain from the patient. And in cases where you have gone for a full mouth rehab, where you are not sure that there are a couple of implants which you have failed, you can even go for a biomarkers to understand that which is a to understand about the progression of the disease, to understand the microbial flora, as also to better know about the future progression of the disease. So you can assess the markers in that. And now these are some of the advanced diagnostic aids, which I thought I'll just mention on. There's a microbiological, biochemical, and genetic test. So these will help you in identifying the active state of the disease, as well as this will help you in understanding the progression of the disease, as well as it will give you a guidance for the estimate the response of the therapy. That is something pertaining to the antibiotic sensitivity test. So it is always better. Now you can go for a microbiological culture, and there are chairside kits are available. Chairside kits are available to understand the active state of the disease, and there further you can responsive therapy can be done specifically to the particular microorganisms by doing an antibiotic sensitivity test. So these are some of the kits which are available, biochemical kits which are available, which are chairside, and microbiological tests what we do to understand the active state of the disease, as well as to understand the response to therapy, as well as to understand the progression of the disease. Now, treatment options of peri-implant diseases, basically broadly it is classified into non-surgical and surgical aspect. Now, this chart gives you an idea about the treatment aspect. Now, we have already covered on ailing, failing, and fail. So remember that what we have spoken on ailing, failing, and fail. And assessment, when you talk what's the assess, how do you assess first? Now, first you get, but when you have the patient, you assess the patient. First, without bone loss, no mobility, there is only peri-implant mucositis. We go for a conventional oral prophylaxis, and you can give an antiseptic mouthwash, oral hygiene instruction, and directly this goes to the maintenance phase. But on the right-hand side, you can see that if there is a mobility, if the mobility is there, it is a failed implant, and it's always better remove the implant and do a retreatment of the implant later. So in the second part, the failing implant, that's bone loss is there, you understand, you analyze whether it's a failing or ailing. Ailing, we have already done the treatment plan on the left-hand side, and the failing is you have a bone loss less than 2 mm. You can go for and pocket depth less than 5 mm. So you go for a conventional debridement, local antibiotic therapy, local drug delivery, antiseptic mouthwash, oral hygiene instruction. Again, assess the patient and then go ahead with the maintenance. But if the bone loss is more than 5 mm and you have to go for a surgical technique, you can do the non-surgical debridement followed by conventional flap with regenerative or resective therapy, and then bring about the surface decontamination by either laser or ozone, whatever it is, and then analyze the situation and put it under the maintenance therapy. So this chart give you an idea about ailing, failing, and failed implant, how to manage or what is the treatment protocol to manage in a ailing, failing, and failed implant. Now, Lang et al. Has bring about a treatment protocol called as cumulative, interceptive, and supportive therapy, CIST protocol, which is called as they have analyzed the probing pocket depth, plaque index, and cratering, and they have come to the conclusion of the treatment protocol. Now, cumulative, interceptive, and supportive therapy, that is probing pocket depth less than 3 mm. That indicates that plaque index in A, the plaque index less than 1 and bleeding on probing negative, or plaque index greater than 1 and bleeding on probing positive, it is mechanical debridement, polishing, and scaling. So this is the treatment protocol for probing pocket depth less than 3 mm or equal to 3 mm. Probing pocket depth 4 to 5 mm, you have mechanical debridement, polishing and scaling, plus antiseptic cleansing, that is, and also 0.1% chlorhexidine gel twice daily with antiseptic cleansing, and for 3 to 4 weeks. So probing pocket depth 4 to 5 mm will be A plus B, And the third one is probing pocket depth, more than 5 mm. That is bleeding on probing positive, no cratering. You directly go ahead with A plus B, that is mechanical debridement plus polishing and scaling plus antiseptic. Local drug delivery, as well as in case of probing pocket depth more than 5 mm, that is bleeding on probing is positive and notable cratering, that is greater than 2 mm, you can do the conventional debridement, polishing, scaling, local antiseptic therapy is done, then followed by third C, that is systemic or local antibiotic therapy. In case of probing pocket depth greater than 5 mm, where notable cratering is less than 2 mm. Now, if the probing pocket depth is more than 5 mm, you have bleeding on probing positive, bone loss is greater than 2 mm, you will have debridement, initially A plus B plus C, then add resective or regenerative surgery along with that. So this is self-explanatory in understanding the treatment protocol of peri-implant disease proposed by Lang et al. So in the BOP positive, in the third one where notable cratering less than 3 mm, 2 mm, they have mentioned the arrow here down. That is in case of positive, in case of molars where the accessibility is less. Once we finish the A plus B plus C, if again the infection persists, you can even think about combining the conventional flap surgery with the regenerative surgery A plus B plus C plus D in that cases. So it is clear that this is a treatment protocol where basically depending upon the depth of the pocket, as well as depending upon the presence of catering, we have analyzed that divided into three protocol. One is conventional non-surgical debridement plus local drug delivery plus systemic or local antibiotic therapy, and then plus resective or regenerative surgery. This was proposed by Lang, and this was again modified by Lang. It's called as an acute protocol, and it was called as the pocket depth less than 3 mm, no plaque or bleeding, no therapy, and pocket depth less than 3 mm, greater than 3 mm is plaque and bleeding and probing is there. It's mechanical cleansing and polishing, your conventional non-surgical debridement, and oral hygiene instructions are given. And pocketing 4 to 5 mm, radiographically no bone loss. It's mechanically cleaning, polishing, oral hygiene instruction plus local anti-infective therapy. And pocket up greater than 5 mm, it's again conventional debridement with a systemic antibiotic therapy along with that. And it's pocket depth more than 5 mm with bone loss greater than 2 mm, we go along with the conventional flap surgery or along with the regenerative surgery or a resective surgery. So it's somewhat similar to what they have done with what the modification was there in the CIST protocol. Only modification what they've added to this, they added radiography along with this acute protocol by Lang. So these are the three classification according to the treatment aspects of peri-implant disease. What I have to add before going to the treatment aspect. So initially we discussed about the classification of implant complications. Then followed by we discussed about the classification of implant failures. Then followed by classification of peri-implant diseases. And now coming to the classification, we have discussed three classifications on peri-implant treatment plan, peri-implant disease treatment plan. Now we go to the treatment of ailing. Now, in case of ailing implant, we have seen in all this treatment protocol, it is basically the treatment to mechanical debridement. The conventional, you do the oral prophylaxis, and you can you can administer local drug delivery, or also in certain cases we can even think about giving antibiotics systemically. Now, the non-surgical debridement in this cases where what we can think about is which include plastic curettes are used for debridement, carbon fiber curettes, there are titanium curettes which are available, and also we can use rubber points, abrasive paste, abrasive air, titanium brush, and also antiseptics such as citric acid, tetracycline, and chlorhexidine has been used, and systemic antibiotics as mentioned here can be given. So this is a non-surgical approach, what we normally do for the ailing implants. And now here, recently the article has come in 2019, where they have mentioned that the formulation of a controlled release material containing metronidazole and doxycycline as a local drug delivery is quite effective along with the conventional debridement as an adjunct along with the conventional debridement in treating peri-implant diseases. Now, other than this, if in case of a traumatic failure, as we mentioned in the earlier classification by Mish and Wang, in case of a traumatic failure, it's always better that you identify whether the failure is because of occlusal factor or because of any pathogenic factor causing the peri-implantitis. So if it's a traumatic failure, what you have to think about the processes design changes or improvement in implant number and position, or even think about first assess the occlusal adjustment, check the premature contacts, check the supra contacts so that the load is not more on the implant surface, which is causing the failure. So occlusal therapy is also, along with the non-surgical, we can consider, which is a factor which has to be considered, which are leading to the implant failures. Now, failing implant, we told that there is a peri-implant bone loss. And when you have peri-implant bone loss, the treatment protocol, as mentioned in the earlier classification, they have mentioned that conventional non-surgical debridement followed by local drug delivery, and you can have a systemic antibiotic given, and followed by conventional flap surgery in deeper pockets, where you can even think about regenerative procedures such as GBR. You can do a guided bone regeneration. And I think on regeneration, detailed discussion was taken on the previous session, I think, by Dr. Rameshwari. So I'm not getting into that. So the failing implant, the treatment option is it's assess the pocket and assess the pocket. If it's a pocket is deeper, you do the conventional non-surgical debridement initially, followed by local and systemic factors. And after that, if assess the healing, and if required, in certain cases where the healing is not satisfactory, you can go for a conventional flap surgical technique along with the regenerative procedures. Now, implantoplasty is also one, because surface polishing by implantoplasty, we bring about surface changes on the implant, because the rough surface on the implant can cause definitely accumulation of plaque and further leading to peri-implantitis. So implant topography should be altered with a high-speed diamond burst, and we polish to create a smooth continuous surface to prevent the inhibition of plaque accumulation. Now, in this, the standard protocol, as per the literature, they use two bursts, that is a regular fine diamond burst and a super fine diamond burst. Then followed by, they use something called as a brownie silicon polisher and a greeny silicon polisher. So this is a standard protocol what they follow, a standard gig. That is a regular fine diamond burr 10S, followed by a super fine diamond burr 10S, followed by a brownie silicon polisher, and followed by a greeny silicon polisher, to create a surface which is smooth and which brings about inhibition of the plaque accumulation, or a surface which is going to create a problem later leading to peri-implantitis. Now, surgical in deeper peri-implant pockets, we told that we can think about a regeneration, and we have to do regeneration, guided bone regeneration using a titanium mesh. All these techniques are available, like in regeneration, we can do along with the conventional flap surgery in a deeper peri-implant pocket. Now, resective surgery is also performed along with, in many cases, where you can see there is a pocket here. So the flap is raised, and you can see the osteoplasty is done. So along with the resective surgery, you do an osteoplasty as well as an implantoplasty, as well as make sure that the flap is sutured apically, and you get a thick keratinized tissue collar along the implant. And as we are doing an implantoplasty along with the alveoloplasty in this case, along with the osteoplasty in this case, it's better that the smooth surface is created on the exposed implant here, so that the further accumulation of plaque accumulation won't be there on that particular site. So this is the procedure. Along with the resective surgery, we include osteoplasty, implantoplasty, and the flap is placed apically and sutured to get a thick keratinized tissue collar around the implant. So there is some other resective implant therapy. What I've gone through in the literature is, in case of a retrograde peri-implantitis, where you are seeing the periapical lesion at the apex of the implant, they even open the flap and resect the apex of the implant and augment the socket. So that is also one part of the resective therapy, what they mentioned in the literature. But as per the literature, what I've got and what I've gone through the resective therapy, I've included these pictures for your information. Now, lasers are also used in peri-implant procedures. Now it's called as a laser-assisted peri-implant procedure. Now laser-assisted peri-implant procedure. Now why we are using lasers? Laser is used in edging to the non-surgical debridement or a surgical debridement. Now, basic idea of using laser is removing the microbe infiltrated oxide layer from the implant surface. And the advantage of using lasers, it does not bring about any thermal change on the implant surface. Now, when you compare a laser, when you see about the laser assisted peri-implant procedure, it's basically a modification of the laser assisted new attachment procedure. So laser assisted peri-implant procedure is when you use a laser assisted peri-implant procedure, it removes the inflamed circular tissue and decontaminate the implant surface. As well as after that, the surface, whatever after you finish the non-surgical, it removes the inflamed sulcular tissue and followed by it decontaminates the laser surface, and then we follow it with a non-surgical debridement. So with the clot which is formed there, it applies, basically the clot which is formed there promotes the healing apicocoronally, and definitely it inhibits the downgrowth of the gingival epithelium in case of a laser assisted peri-implant procedures. So the basic idea is you assess, you do the laser assisted basically to remove the microbe infiltrated oxide layer on the implant surface and decontaminate surface without any thermal change as an adjunct to the non-surgical or surgical procedures. So a lot of literatures have shown that there is an immense, comparatively the results are good when you incorporate the laser along with your peri-implant procedures. Ozone therapy is also one adjunct along with your non-surgical debridement, where it is commonly used in the form of ozone water. And ozone has got a strong antioxidizing agent, and it prevents it, and it's got a strong antimicrobial activity. And ozone that
Yeah, there are some connection issues from Anil sir's side. We'll just wait for some time. Please wait for some time. There are some connection issues on Anil sir's side. We're just sorting it out. Sir. There is some technical glitch on Anil sir's side, so we're just trying to sort it out. Please be patient. Please be with us. Yes, Anil sir, can you hear me?
Yeah, that is a net issue.
Okay,
Yes,
okay,
it's
sir.
clear.
Sir, yes, sir. Now it's your back. Please share your screen, sir.
Yeah. Okay.
No, we can't see your screen, sir.
Nahin.
Mhm.
You can
Yeah.
see now.
Yes, yes. Now it has come.
Is it okay?
Yes, sir.
Is it okay?
Yes,
Yeah.
sir.
Yeah, sorry, this is because of the net issue. I don't know what is the reason now. I'm using my hotspot and I'm back to the webinar. Thank you for helping me out. And we start with the retrograde peri-implantitis. So just recapping what we have finished. Initially, we started off with the classification of implant complications, followed by classification of implant failures. Then we spoke about peri-implant diseases and then classification of peri-implantitis, then classification of peri-implant soft tissue deficiencies by deficiencies, then followed by we had a classification on treatment protocol on peri-implant disease, and then management part we spoke till ozone therapy, and now retrograde peri-implantitis. This is basically normally we see that the mainly because the persisting periapical lesion, which does not subside, which is causing the retrograde peri-implantitis. And sometimes the literature has also shown that when you do area is not late and certain infection, which is also causing retrograde peri-implantitis. So depending upon the periapical lesion, as I told you, there is some resective therapy in severe cases where if the implant length is long, or if you want to remove the apex of the implant and then augment also, it's possible. And depending upon the lesion, we decide if in cases the prognosis is poor, we go for an implant extraction, or then the cases what I've told, we can also think about periapical surgery, debridement, regenerative, and local decontamination and antibiotics. So this is about retrograde peri-implantitis. The percentage of retrograde peri-implantitis is comparatively very, very less when you compare with the peri-implantitis as such. Now, finally, it's an implant, the failed implant. In case of failed implant, we implant with mobility. That is, if in case of it's a severe peri-implant bone loss or unfavorable bone defect, host response is bad, and ineffective surgical therapy, rapid wound discharging. These are all the factors what we put under the failed implants. And the treatment aspect will be remove the implant, analyze the situation, and in case later, if you want to augment the bone and go for an implant, that is also possible depending upon the cause of failure, and you analyze and then go for a treatment plan. So this is all about ailing, failing, and failed implant, and the classification, and about the treatment therapy as such. Now, it's very important that in an implant practice, because you have to have a team approach, because you have a dental implant, you place an implant, you need a prosthodontist when you plan an implant, and lab to lab, you need an initial good diagnostic tool to understand what type of implant you have to, what is the size of your place. So it's basically a teamwork, and especially when you're going for a full mouth implant placement, full mouth rehabilitation, it's always better that the team is there with you to help you out. There's no problem like what we discussed earlier about the surgeon stage or restorative person stage. But finally, it's important is to understand that the implant should not fail, and we have to have a better prognosis for a long time. So identifying all this what we have discussed, and if you can put the classification into place in analyzing it, which help in the treatment plan for the patient of peri-implant disease. Now, success is the ability to go from failure to failure without losing your enthusiasm. We see in all cases, we see successful people as only the success part we see in them. We never see the dedication, the hard work, the compromises what they have done, or the sacrifices what they have done, and they would have gone through different phases, but they have been persistent enough to achieve that success in their life as well as their practice. I'm talking about your dental implantologist, for example, when you see a dental successful implantologist as such, we have not seen that what all they have gone through. And so it is always better that considering all these factors, what we have mentioned, go through an adequate training and a complete protocol, including the importance to maintenance to come to achieve the success in implantology practice. Now, it's equally important to the summary. It's equally important that you have to emphasize on the maintenance therapy. So I've seen that the possibility of developing inflammation and infection or any complication also should be there in the consent form, which will be helpful for you later to tell the patient about, or any problem persists, you can tell the patient that it's been informed earlier. So same time, maintenance schedule also should be given. So in some of the articles, I've seen that the first visit, or the first after the loading, after the restorative phase, the first year they have 3 visits, that is 3, 6, and 9 months. And followed by the second year, they have 2 visits, followed by the third year onwards, 1 visit mandatory. So you can have a maintenance chart for each implant patient, so that will help you in giving an idea whether the patient has visited you, or that will also help you in guiding that is the status of the patient. The maintenance chart will give you an idea of the prognosis of this particular case also. Because it's very important, we have seen that the articles earlier, that's a prevalence of peri-implant mucositis. So if the peri-implant mucositis is not controlled, the chances are that it can lead to the peri-implant lesion at the earliest. So it's always important to make sure that the maintenance therapy is also equally important and placement the restorative part. So this goes as the implant placement, the restorative phase, and the third one with the maintenance phase, which is equally important and which probably can be done with the charting properly in the maintenance therapy. So I conclude by saying that paucity of well-controlled scientific evidence against the backdrop of increasing prevalence of peri-implant mucositis and peri-implantitis, and a lack of robust evidence-based treatment options make the prevention of peri-implant disease. Classifications pertaining to understand etiology as well as understand the treatment plan or understand the clinical scenario of peri-implantitis, as well as what I mentioned about the advanced diagnostic aids to understand the active disease, to understand the disease progression, as well as to estimate the response therapy about what you're doing on this peri-implant lesion are available. So peri-implant diseases are definitely treatable, and also the peri-implantitis as such, if you identify the complications or in advance, that will be helpful for the treatment part of the peri-implant disease. Once again, I thank Madam and Dr.
Hello. 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 I think we have again lost the connection from Sir's side. We'll just try to get him back for questions. Yes, sir.
Yeah.
Yes. So there are a few questions from the students. So I'll just take few questions one by one. The first question is, how much is the biologic width around implants?
Hello.
Hello. Yes, sir.
Yeah.
Yes. The first question is, how much is the biologic width around implants?
Hello.
Hello. I just a minute, sir. Hello.
Doon chantas ठेवल्या
Sir, can you? Hello. 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 Sir, I think the connection has freezed from your side. Hello. Hello. I think there are some network issues from sir's side. Yes, sir. We are just waiting for sir to join back. Yes, sir. Hello. Yes,
Okay.
sir. Welcome back, sir. Yes, sir. Yes, sir. We can listen. We can
Yeah.
hear you.
So I'll
Welcome.
send my email ID for anyone who wants a presentation. I can send it to them. Okay.
Yes. Yes, sir.
Bolo.
So the first question is, how much is the biologic width around implants?
As per literature, I think the biology bit what they mentioned is comparatively more. That's 3 to 4 the in the implants when you compare with this 2.07 the natural tooth. So that is what is the 3 to 4
Okay. So, second question is, what is the standardized method for measuring probing depth around implants?
Standardized.
Method for measuring probing depth around implants.
Standardized measure, probably I'm not very sure about that. Probably I have to look into that.
Next is, what is the ideal time for implant loading in various regions of maxilla and mandible?
See, it depends on normally as per literature now. As per there is a classification on implant loading also. When it is the straightforward case of D1 and D2, normally the loading time what they mentioned is 3 to 4 months. But if it's a regenerative therapy along with the conventional surgery, normally the procedure what the time period they mentioned is 6 to 9 months, depending upon the involvement of the defect. That is what as per the literature what they're shown as classification.
Okay. Thank you, sir. Next is, when normal probing depth is 4 to 5 millimeter, then how can we follow CIST protocol?
No, CAST protocol is its last they have mentioned that probably they have not mentioned understood that more than 4 is basically A plus B plus C plus D. That is a conventional non-surgical debridement plus along with your regular regenerative and resective therapy. So there is an option other than more than 4 also. It's the last option what they're given in the CIST protocol. And that is modified in acute protocol where they have clearly mentioned that the radiograph or the pocket depth more than 5 is along with the conventional debridement plus along with the flap surgery.
Okay. So next question is, what is the protocol for placement of implants in infected sites?
We are talking about the negative factors. We have clearly mentioned that what are the negative factors, what will lead to implant failure. So it is always better in compromised cases, the systemic situation as well as the infectious site, whatever you're talking about, take care of that first and then only think about implant placement rather than compromise placement of implant. That is what we discussed in cases where there is a failure in factors contributing to peri-implantitis because persisting periodontal lesion and persisting periapical lesion. That is also one entity which will contribute to the factors of failures in peri-implantitis.
Okay. So we have one more question. Can you explain regarding implant dehiscence management?
Implant?
Dehiscence management.
That is what we have, according to classification, the peri-implant soft tissue dehiscence we have mentioned. No, so PSTD 1, 2, 3, and 4. In the 1 and 2, what they have mentioned is basically it is the connective tissue graft along with the coronally advanced flap in 1 and 2, because in 1 there is no recession as such, but there is a soft tissue thickness is comparatively less. That is why the implant and the abutment is visible. So 1 and 2, where the second is just the emergence profile, the line connecting the emergence profile is more on the palatal side. So for the soft tissue emergence in the anterior, for the 1 and 2, they preferred the treatment aspect. In that article itself, they have mentioned that the 1 and 2, PSTD 1 and 2, it will be CAF plus coronally advanced flap plus your connective tissue graft. And 3 and 4, depending upon the head of the implant, the palatal, and the buccal, you will have to have a prosthetic approach along with the along with the other two therapies what I mentioned for that. Otherwise, you have to go for a angulated abutment, or in cases of 4, where it is placed on the facial side, more you will have to go for a retreatment of the implant also for the aesthetic reasons. So that is clearly mentioned in the article on the 4 aspects, the treatment also.
Okay, sir. Thank you very much for your presentation, and few of the questions we have taken today. Others questions you can directly direct.
Hello? Yeah. Hello? Yeah, your voice is breaking, Neeraj.
Yeah, so we are signing off now. Thank you very much for the wonderful lecture, sir. It was really wonderful to listen to you.
Thank you so much for your cooperation and patience, in conducting all the webinar series. Thank you so much, ISP. Thank you, President and Secretary, for giving me an opportunity. And thank you, dear PG students. Wish you all the best for your exams, as well as take care, stay safe. Very important.